Good afternoon, and welcome to this edition of HDSA and Me. Over the next 3 sessions, Dr. Martha Nance from our HDSA Center of Excellence at Hennepin Healthcare will take us on a journey to explore Huntington's disease. This week in HD 101, Dr. Nance will give us a refresher on the typical symptoms and challenges of HD. On May 27th in HD 202, Dr. Nance will focus on the care needs of people with Huntington's disease as the disease progresses and how to optimize daily life throughout the course of the disease. And on June 17th, HD 303 will examine our hopes and goals for the future and how the HD medical research and advocacy communities can work together to achieve better lives for people with HD and their families. We hope you'll be able to join us for this exciting series. You can register for these sessions by going to hdsa.org/HDSA and me. As a reminder, you can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and press enter. Your questions will be answered at the end of the session. This presentation will be available in about a week on HDSA's YouTube channel. And now a little about our speaker. Martha Nance is a neurologist and geneticist who has served as medical director of the HDSA Center of Excellence at Hennepin Healthcare in Minneapolis, Minnesota since 1991. She's an active clinician and has also participated in many HD clinical trials, as well as serving on the executive committee of the Huntington Study Group twice. Co-authored A Physician's Guide to the Management of Huntington's Disease, 3rd edition, and wrote the Juvenile HD Handbook, both published by HDSA. She's particularly interested in genetic testing, juvenile HD, and care of late-stage HD. We're delighted to welcome Dr. Nance here today, and I'll turn the broadcast over to her.
Well, thanks so much, Deb, and hopefully you can hear me and hopefully you can see the slides and the technology is working. So this is part of the HDSA and Me series. So now I can't advance the slides. Oh, there it goes. So this is, as Deb mentioned, is intended to be sort of a review or perhaps a talk for people who are sort of new to Huntington's disease. I think it's a reasonable review even for people who already know about Huntington's disease, just to make sure we're kind of all on the same page. Hopefully I'll only talk for maybe 30 or 40 minutes, so there should be time for questions at the end. It is important to understand that anything that I say that sounds like a treatment recommendation is just for information. You should always go to your own physician. You can certainly say, well, Dr. Nance suggested this kind of thing, but it's up to you and your doctor to determine your treatment approach. And then my disclosures, I do get grant support from HDSA as part of our Center of Excellence recognition. I work with the Huntington Study Group and receive honoraria for some of the things I do with them. I have had paid consulting roles with several of the companies that are involved in research studies in HD, and I'm also on the steering committee for a study called Connect HD that's sponsored by a company called Neurocrine. So I'm going to try to answer these questions during the course of today's talk. And these are just questions I think people just routinely ask. How many people have HD? How do you diagnose HD? What are the typical symptoms? What causes HD? And I'm going to be a little bit heavy-handed about the genetics, partly because that's my thing, and partly because it's something that I think people still don't understand. There's still a lot of misunderstanding about the genetics of HD. What treatments are there? How does it progress? And then most importantly, at the end, we're going to talk about what can you do to help yourself. I think often with a diagnosis of Huntington's disease, really diagnosis of any serious illness, that it's accompanied by a loss of control and a sense of helplessness. And Huntington's disease goes on for a long time, and there's a lot that you can do during the course of your disease to influence things in a favorable way. So first question, how many people have HD? And that's kind of an odd question in how we answer it. The party line for decades, quite literally decades, has been 30,000 people in the US have Huntington's disease. And that is really based on work done in the 1960s. And you just can't believe that that's actually correct. Sometimes it's written that the frequency is something like 4 to 7 per 100,000 people in the Caucasian populations. If you do the math, if the US population is 330 million, that actually calculates out to a little bit less than 30,000. I saw in somebody else's, one of my fellow colleagues was sort of blogging the other day and wrote, somehow had a magical number of 43,000, or maybe it was 47,000. Anyway, it's more than 10,000. It's probably less than 100,000. But for every affected person, there are also siblings and children who are at immediate 50% risk of developing Huntington's disease. And, you know, statistically, half the people who are at risk are ultimately going to get HD. So you are not alone. There are many people around. Sometimes it's hard to find them, particularly in the COVID era. And attending lectures like this is one way to begin to be connected. What are the typical symptoms of Huntington's disease? And I try to divide the symptoms into several different categories, and just to make it, you know, kind of rhyme a little bit or be alliterative. I tried to, you know, I live in Minnesota, the land of 3M, but Huntington's disease is the land of 4M. So you've got symptoms that relate to movement, symptoms that relate to thinking and mental processing, or what I've called here memory, although memory is kind of the least of it. Changes in mood or behavior, and then changes in what I would call metabolism. So what kinds of movement symptoms do we see? Well, the most famous kind of movement abnormality in Huntington's is what we call chorea. Those are the sort of involuntary dance-like movements that occur fairly commonly. Because those are so visible to other people, the disease actually used to be called Huntington's chorea. We really don't use that term anymore. We call it Huntington's disease because not everybody has chorea. Some people who have chorea, it's really not very prominent. And there are an awful lot of other symptoms that make up the core features of Huntington's, and to really emphasize chorea underemphasizes some of the symptoms that may be more disabling in other people. So in addition to the involuntary movements, the presence of movements when you're not trying to move, people with Huntington's disease also have difficulty doing movements that they want to do. And in general, you could just say that that's a loss of coordination or incoordination. It can affect the arms, the legs, the tongue and lips. So the walking may be impaired, the ability to hold things and accurately grab things and reach a target or write, all those things can be impaired. The loss of coordination in the tongue and lips leads to two different symptoms. One would be dysarthria, which is a change in the speech, a sort of slurring of the speech. And the other is difficulty with chewing and swallowing, which we call dysphagia. So what about what I've called here memory problems? It's really not so much memory. People with Huntington's disease don't forget things as one of the prominent features. One of the early changes in cognition in Huntington's disease is a change in what we call executive functions. What are those? Executive functions are the things that executives have to do. They have to plan, they have to sequence, they have to get started on a task, they have to make decisions and judgment calls, they have to multitask, get distracted by something and then get back on track again. And those are some of the most difficult things for people with Huntington's disease to do, often very early in the course of the disease. And then fairly quickly, there's going to be difficulty learning new skills. And this often plays into work-related issues. If you're working at a job that requires multitasking and judgment calls and things like that, and you're having trouble with that job, quite often people would have difficulty retraining for some different job, even if it's a quote lesser job, just because the Huntington's may affect your ability to kind of learn new things and remember them. And then eventually the kind of ugly word that we use for changes in cognition that get worse over time, we use the yucky word dementia. But when people say dementia, if you say that to friends or somebody you meet on the street, they have in mind most likely somebody with Alzheimer's disease. Alzheimer's disease, the primary feature is dementia. And so that's kind of what we think of when we say dementia. Our minds kind of flip immediately to Alzheimer's disease. The details of the cognitive troubles in Huntington's and in Alzheimer's are quite different. And so yes, they both lead to dementia, but exactly what it sort of looks like or feels like is different between the two diseases. What about mood changes? Well, depression, anxiety are quite common. Of course, depression and anxiety are quite common in people who don't have Huntington's disease. So we really struggle to pin a diagnosis of Huntington's on somebody just because they have depression or anxiety. Impulsiveness is pretty common, and that's something that's a little bit special. It's not unique, but it's certainly something we see fairly commonly in HD and not so commonly in other conditions like Alzheimer's or Parkinson's. Paranoia, suspiciousness, hallucinations, and then there's a whole raft of other symptoms or behavioral changes that we see in some patients. But probably the most common ones are depression, anxiety, and impulsiveness. And then what about metabolism? What do I mean by that? Well, most of my patients with Huntington's disease are happy to eat. They like to eat, they enjoy eating, but they lose weight anyway. And oftentimes my patients are the kind of people who are hot. So here in Minnesota in January, they've got the window open and they're wearing a t-shirt and shorts, which believe me, the rest of us in Minnesota do not do that. Have the fan blowing because they're just sort of hot. So it almost feels like people with Huntington's disease use up calories sort of just generating heat, but are not really able to put on weight. Sometimes the weight loss is due to all those extra movements, but we sometimes see weight loss even in people who don't have a whole lot of chorea. So those are some of the common symptoms. There are many other things that can occur in people with Huntington's disease. So sleep disturbances are pretty common. And we'll talk about some of the other challenges and as well as symptoms both in this talk and in the next one. So how do you diagnose Huntington's disease? Well, you kind of have to go to a doctor, and that's me. See, there I am with my blonde hair and my stethoscope. So what does the doctor do? Well, they listen to you describe your symptoms, other things that have gone on in your medical history, what medications you're taking. There are certain medications that might mimic, whose side effects might mimic some of the features of Huntington's disease. It's also important to know kind of what your life situation is, or what we refer to as your social history. Are you going to school? Are you married? Do you smoke? Do you use illicit drugs, alcohol? Do you exercise? A whole lot of things that may play in both to the diagnosis, but also to the treatment or management. And obviously for Huntington's disease, it's a genetic disease, so the family history is particularly important. We'll ask about mother, father, grandparents, siblings, and so on. And then we do a neurologic exam. And if the suspicion is you got somebody who's got a family history of Huntington's and they have symptoms that sound and look like Huntington's disease, the most efficient diagnostic test to do is just do the HD gene test. From the patient point of view, it's a simple blood draw. It's the lab work itself is not all that expensive. It's cheaper than an MRI scan. And an MRI scan doesn't really make a specific diagnosis of Huntington's disease. Now, if you're not sure as the physician, it's the person doesn't have a family history of Huntington's, or there's some symptom that's atypical, or there's a piece of the story missing, then you might well do tests to look for other conditions to rule out other things. MRI scan to make sure you're not missing a stroke or a brain tumor or something else. But in a person who comes from an HD family and has symptoms consistent with HD, the most efficient test to do is the blood test, the gene test. I often, when I give this talk to physicians or healthcare providers, I often refer to these symptoms as the care-defining characteristics of Huntington's disease, but I think it's reasonable to think about from the patient and family perspective as well, to sort of help you understand what kind of interactions you're going to have with the medical community. This is basically a neurologic disease. It causes movement problems, cognitive problems, psychiatric problems. So the kind of doctors that you're going to see to specialize in this or manage it are going to be neurologists or psychiatrists or both. It's typically an adult onset disease, usually middle adulthood, but occasionally, importantly, occasionally it starts in childhood or in old age. It is a chronic disease, so it's worthwhile to find a doctor that you get along with, because you're going to be seeing that doctor for a while. And it's also important not to neglect your general health, because the course of Huntington's disease goes on for years or a couple decades. And so you don't want to neglect your dental health or, your general medical health in the midst of all that. But it does progress, and until we find a cure, it is ultimately fatal. So it is not unexpected that things will change during the course of the disease. And then one of the unique aspects about Huntington's disease, of course, is that it's genetic. It's a dominantly inherited genetic disease. And just kind of by definition, genetic conditions affect the whole family. It may be one person or another who has the abnormal gene, but the whole family is impacted by the disease. So who gets Huntington's and when? As I said before, the onset is typically in middle adulthood, maybe age 30 to 50, but I have had a patient whose symptoms started when they were 2. And I have another patient, I haven't seen her for a couple of years, but I saw her 74-year-old son yesterday. This lady is now 97 years old. So the symptoms of HD can present, there's a huge range around that age 30 to 50. It is equally likely to affect males and females. So if for some reason it only seems to hit the men in your family, that is just happenstance. Or if, last generation it was all the men, and this generation it's all women, that's just happenstance. It's equally likely to affect men and women. As I said, maybe 5% of people have what we call juvenile onset Huntington's disease, onset before age 18. The typical course is maybe 10, 20 years after the diagnosis. And importantly, there's usually a family history of Huntington's disease, but not always. So how could you get Huntington's if nobody else has had it? Well, perhaps you were adopted and didn't know that. Perhaps your biological father is not the same person as your the person you consider to be your father. And then there are maybe 5 or 6% of people with Huntington's disease who truly have what we would call a new mutation. Nobody else in the family's ever had Huntington's disease before, and there it is. So how does that happen? We'll kind of explain that in a minute. So what causes Huntington's disease? Huntington's is always caused by the same thing. It is caused by a mutation in a gene that we call Huntington, or some people abbreviate it HTT. So it's a mutation in the HTT gene. I will often just refer to it as the HD gene. But you need to understand that everybody has an HD gene. In fact, everybody gets 2 copies of the HD gene. As you see on the lower left, everybody got a recipe for Huntington from dad, and everybody also got a recipe for Huntington from mom. And so we all have 2 copies of the HD gene. What is a gene? It is a recipe that tells the cell how to make a particular protein. There's something like 25,000 or 30,000 different genes. So you have a pretty big recipe book sitting inside each of your cells. And it only takes 1 copy of an abnormal Huntington gene to cause HD. So in the lower left, you see a recipe from dad. If you look carefully in the second line, it has that word CAG repeated 3 times in a row. But if you look at the recipe from mom, it looks the same, except for that CAG. Somehow somebody's finger got stuck on the keyboard, and that word CAG seems to be repeated a number of times in a row. And so mom's recipe for Huntington ends up being sort of a longer recipe that, you stick more of these, whatever these CAG things are. I always think of them as chocolate chips in a chocolate chip cookie. So, you know, you've got a recipe from dad that puts 3 chips into the cookie. You got a recipe from mom that puts 11 chips into the cookie. And pretty soon you put too many chocolate chips into the chocolate chip cookie and the cookie just sort of crumbles and falls apart and it doesn't make a cookie anymore. And so it's the same kind of thing. If you have this word CAG repeated too many times in a row, then you make the Huntington protein that kind of falls apart and doesn't do what it's supposed to do. And the hallmark of what we call a dominantly inherited disorder is that the abnormal gene seems to dominate over the normal gene. So even though you got a normal recipe from dad, that doesn't hide the fact that you got an abnormal recipe for Huntington from mom that's churning out this abnormal chocolate chip cookie that's crumbling in a little heap and clogging up the oven. And pretty soon you can't use the oven anymore because it's so full of crusted chocolate chips. So at first pass, Huntington's disease is caused by what we call a CAG repeat expansion, that word CAG being repeated too many times in a row within this gene that is supposed to encode a recipe for a protein called Huntington. We know just by looking at a lot of people that anything from 10 to 35 CAG repeats is normal, and 36 or more CAG repeats is not normal and can cause Huntington's disease. Now, there's some more things to know about this, and you'll see this pyramid again in a minute. So first, many people who see patients and have laboratories have drawn little graphs like this. So on the x-axis going across is the number of CAG repeats, starting at probably the smallest one here is 38 repeats. And then the biggest one is something like 62 repeats on this particular graph. And then the vertical axis is how old the person, it's years. And the blue dots are the age at the time of diagnosis. And then the red dots are how many years passed between diagnosis and death. And you can see that from the red dots, how big your repeat number is doesn't seem to make a difference in terms of how many years you live after diagnosis of HD. It's about 15 years for if you have 38 repeats, and it's about 15 years if you have 62 repeats. But for the onset age, there is a big difference depending on the repeat number. So if we look at the 39 repeats, there's somebody here who had the onset of Huntington's at age something like 38. And there's somebody else who had onset of Huntington's symptoms at age 76. And these are all people who had 38 repeats. And then if you go out to the 50 and 60 repeats, these are all younger onset ages. So the bigger the repeat number, the younger the onset tends to be. So the size of the CAG repeat sequence is one factor that determines when the symptoms are going to begin. It's not the only factor, because as you can see, the range of onset ages for people with 38 repeats was anything from age 38 to age 76. They all had the same repeat number, but they had different onset ages. So there must be other factors that also influence the onset age, and we're working to figure out what those factors might be. Another important thing to understand is that repeat numbers can change when they pass from parent to child. They can get smaller, but they tend to get bigger. So a parent who has 40 repeats will someday get Huntington's disease. When they pass that gene on to the child may have 39 repeats. The child may have 45 repeats. Either of those is possible. And the tendency for the repeat number to get bigger is more noticeable in general when the gene is passed on by a guy than a girl. And that correlates with the fourth point here, which is most children with juvenile onset Huntington's disease have very big repeat numbers, and the majority of children with juvenile onset Huntington's disease have an affected father. How are you going to get 58 repeats? Well, it's probably a big jump from a parent who had 48 repeats, and that big jump in repeat number is more likely to occur when the gene is passed on by a guy than a girl. a woman passing on an abnormal gene, it tends to be plus or minus 2 or 3 or 4 of whatever the mother's repeat number is. Now, anything can happen. This is just sort of a general observation. And then if you look carefully at this, you can see that most people in here have repeat numbers in that 40 to 45 range. So a lot of the work that's being done, research that's being done, tends to focus on people with repeat numbers in the 40 to 50 range, because that's simply, we have more patients with repeat numbers in that range than we do people with repeat numbers of 37 or 58. So each child of a person with Huntington's disease in the usual situation has a 50% chance of inheriting the parent's abnormal gene. So remember, everybody has 2 copies of the gene, and unless both of your parents had Huntington's disease, if one parent is normal and the other parent had Huntington's, you're going to get a normal copy of the gene from the normal parent, and you have a 50% chance of getting your parent's abnormal gene. If you get that abnormal gene, you will get Huntington's disease. So Huntington's disease does not skip generations. Anybody who has the abnormal gene will get symptoms of Huntington's disease unless they died in a car accident at age 30. You know, so if somebody died young, maybe they would have gotten Huntington's had they lived longer. And occasionally people are still misdiagnosed. I think this happened more in past generations before we had a gene test. My patients used to say, well, my grandpa, you know, was felt to be alcoholic and we didn't really ever see him. And my mother, well, she just had psychiatric symptoms. And, you know, maybe the diagnosis of Huntington's wasn't made. I think in today's world in the US, most, well, maybe I should pause before saying that. In my clinic, everybody gets a gene test. And so, so I would, you know if somebody really has Huntington's or not, but maybe misdiagnosis can still occur or lack of diagnosis. And then it is possible to be the first person in the family ever to have Huntington's disease. So as I said, that occurs maybe 5 or 6% of the time. How can that be? Well, remember I said the repeat number can change as it passes from parent to child. So if a parent has 33 repeats, they'll be normal, they won't get Huntington's disease, but they may pass that gene on to their child, and then the child has 38 repeats or 42 repeats. And that person then develops Huntington's disease, first person in the family ever to have it. So people with repeat numbers in the high normal range can be associated with the being parents of a, quote, new mutation patient. And because of that correlation with the age of onset and the number of repeats, as I said, here's somebody with 39 repeats who didn't have onset until age 76. Well, that person could easily have, had a heart attack at age 70 and died, and then you would then you'd say, well, that was an abnormal gene, but it didn't cause symptoms within a normal lifespan. So back to this pyramid, if we sort of refine the definition of normal and abnormal, remember I said before 10 to 35 is normal. Well, 10 to 26 is normal. 27 to 35 is also normal, but these are the repeat numbers that have been reported in the parents of patients with, quote, new mutations. So I'm referring to that in this as high normal. And then people with 36 to 39 repeats, anything over 36 is not normal and can cause Huntington's disease. But we do occasionally see people with 38 or 39 repeats who live a full, happy lifetime, die at age 75 or 80 of something else, and never got Huntington's disease. And the genetics word for that is reduced penetrance. And then pretty much anybody with 40 or more repeats who has a gene with 40 or 4 repeats is going to develop Huntington's within a normal lifespan. So enough about genetics. And you can certainly ask questions at the end about that. What about treatment for Huntington's? We have medications for chorea. We have medications for the mood and behavior issues. We do not currently have any medications to treat the coordination troubles. We do not have any specific medications for memory troubles in Huntington's disease. But this is what my center of excellence looks like. There's a lot more to being adequately cared for than just going to the doctor and getting prescriptions. So in our clinic, we have a neurologist, a psychologist, a neuropsychologist, a genetic counselor, social worker, physical therapy, occupational therapy, speech therapy, dietitian, a nurse kind of care manager. We have a research nurse, and all of these people come together to try to help the person with Huntington's disease and the family. Our model of care is that we really think of the person with Huntington's disease as being surrounded by the core of immediate family. Some people are fortunate to have extended family. There's also your community, whatever that might be, whether it's school or faith community, or a work community or a neighborhood community. And then the center of excellence. And we really try to support all these people as they try to support the person with Huntington's disease. We also think that that just, providing the care of today, prescribing pills is sort of not all there is to be done. Everybody needs to understand Huntington's disease. That's what this is: education, support for patients and families as they go through the course of their disease. And then research is integral. I always say the patients of today are uniquely qualified to help us find better treatments for tomorrow. We cannot find better treatments just by sitting in our basement labs with test tubes. At some point, you have to try your treatment on a person with Huntington's disease and find out if it works. And so we really have to partner with our patients to develop better treatments for tomorrow. Until we find a cure, Huntington's disease will always progress, and people always want to know, what stage am I at? And I've used this particular staging system for decades, and I find it to be useful. It's called the Schosen-Fahn Total Functional Capacity Scale. The maximum points is 13, and it's divided into 5 stages. You can read that on the slide. What I like about it is that it really measures things that are just stuff anybody can figure out. Are you working? Are you having trouble at work? Could you at least do volunteer work? Or no, not at all. Do you do chores at home? Do you do no chores at all? Or do you kind of do some chores, but not everything that you always used to do? What about managing money? What about doing ADLs, stands for activities of daily living, which is things like bathing, dressing, preparing a meal, and so on. Do you do your ADLs completely by yourself? Do you get a little bit of help with zipping and buttoning? Do you maybe do some ADLs, but mostly somebody else helps you do them? Or do you really not do anything at all? And so you can sort of add up the points and see what stage you're at. And it's sort of as obvious that certain issues come up at certain stages. So stage 1, you're not worried about buying a wheelchair. You're worried about whether you're able to work, you're getting diagnosed, there's a slight change in relationships. We often don't even see people in stage 1. We often see people in stage 2 because they've slipped down to a 0 on the working scale and need to get a diagnosis of HD so that they can get on disability. And then driving is an issue. But stage 2 is a time that people can continue to enjoy life and travel and maybe even do volunteer work. Stage 3 is sort of a big transition time when you go from being relatively independent to, by the time a person is stage 4, they're really basically needing 24-hour help. So stage 4 and 5, the later stages of the disease, you really need probably hands-on help. So I find this to be a useful scale in sort of for people who have symptoms of HD. How is the disease progressing? But truly, it's a disease that extends from birth until death. And I think if or as we develop treatments that change the course of the disease, which we don't have yet, we will want to stop thinking of this disease as being a thing where you only go to the doctor when you've got enough chorea that the medical student can make the diagnosis, or you only go to the doctor when you need to get on disability. If we have a treatment that changes the course of the disease, then obviously we're going to want to treat it much earlier. So really this is a disease, the gene is there from before you're born until the day you die. It's a disease that lasts from birth to death. But of course, you know, death comes sometimes after 20 years and sometimes after 97 years. So, and I often think in terms of kind of milestones. So there's sort of life milestones like, you know, finishing school, getting married, having your child, being disabled from work, movement, you know, where do you live? And then there's sort of disease milestones. So, you know, Huntington's starts impacting as soon as you become aware that there's somebody in the family with the disease, which is often when you're a child or a teenager that a parent develops symptoms. And then maybe you have predictive testing, or maybe you don't. Then maybe your affected parent dies, and somewhere in there you become aware of symptoms in yourself, and then the diagnosis, and so on and so on. So it's the course is really a lifelong course, and taking a broad view of care, we should provide care throughout that lifelong course. I'm not going to read every word on this slide, but I just want to make the point that as the disease progresses, and I'll talk a little bit more about this in the next lecture, the HD 202 lecture, what do all these people do? And the fact that you don't just sort of go see everybody once and then, well, I did that. One might revisit some of these folks during the course of the disease. So the behavioral symptoms or mood changes may be terrible at the onset of the disease and then sort of subside and then sort of brew again at a later time. So seeing the psychologist later. Speech changes or swallowing difficulties often sort of get worse as the disease goes on. I have everybody see my dietitian on day one to talk about healthy eating and to get a sense of what your baseline calorie intake is. Where do you get money to buy food? Who prepares the food? Are there different textures of foods that would be easier to swallow, and so on? So again, all these people can play a role in optimizing the day-to-day life of somebody with Huntington's disease. And by the way, there's also the lay organization. There's dental care. Don't neglect your dental care. If you've got Huntington's disease, it's hard enough to talk and chew, let alone if you never brush your teeth and never go to the dentist and end up having your teeth pulled. People with Huntington's disease have a heck of a time keeping dentures in place. So you'd rather keep your own teeth. So go to the dentist. And then, as I said, general age appropriate care. So I want to end with what can I do? You know, I've got Huntington's disease. What can I do to make my own life better? And the first thing is to build your community. It's the challenging situations are the ones where people have really burned their bridges with their own family. When the going gets tough, most of us lean on our families. I think the year of COVID has really hammered that home. I have many patients where the adult kids came back home or never left, and I'm seeing more blended living situations where you have 3 or 4 generations in one house. So, you know, surround yourself with family, build a community early in the course of the disease so that you have people there at your side when the going gets tough later on. And then attend to the basics, you know, eat right, drink enough fluids, exercise. This is a disease that wants to take away your control of your movements. How do you fight that? Well, how about doing controlled movements? And whether that's playing basketball or doing yoga or running or pedaling a bike or canoeing, you know, really, it doesn't matter. The idea is to do movements that you want to do in a way or a manner that you want to do them, and then you give yourself a gold star for fighting Huntington's disease. But then you need to rest when you need rest. So if you're, you know, working 20 hours a day and running yourself ragged, that's a stressful thing to do. It's not going to help. Do things you enjoy and be with people that you care about and who care about you. And you know which of these boxes you can check and which things you're kind of not doing. And I think even maybe the people speaking to you right now aren't quite exactly checking all these boxes the way they should. And, you know, so attend to the basics, particularly things that you are failing to attend to at the moment. So if you're not exercising, get off the couch and go for a walk and take advantage of this wonderful summer now that we can finally get out again. And then finally, be aware and not afraid. So I think there still seems to be stigma associated with saying the word Huntington's disease. We need to stop that. This is a bad disease. There's lots of bad diseases. ALS is a bad disease. Alzheimer's is a bad disease. You know, HIV, COVID, they're all bad diseases. So, you know, the more that you stand up and invite people to walk the walk with you, the stronger you'll be. So participate in seminars like this one. Participate in HD research studies if they become available to you. Currently, the Connect HD study is struggling to enroll enough subjects. People enrolled in the Roche trial, the one looking at that was just recently terminated, that looked at a treatment to reduce the Huntington level, but we're having trouble getting people to participate in this trial of a drug to treat the chorea. And then staying up to date, I think, you know, HDSA does a wonderful job of bringing educational resources, but also seminars and courses, and the annual conference comes up in June. And then live your life to the fullest. So I'll talk more about just sort of how do you navigate the healthcare system, what kinds of treatments might you need as you go through the course of Huntington's disease. I'll talk about that in the next presentation, the HD 202, in a couple of weeks. But now I'd like to just take some questions.
Okay. Yes, so I want to remind everyone that we are taking questions through the chat box. So if you have a question for Dr. Nance, just go to the chat function, type in your question, and then press enter. And we'll be able to see your questions in the chat box. We do have a few that have come in during your talk. And the first one is, how is the dementia associated with HD different from dementia associated with Alzheimer's?
So Alzheimer's tends to be heavier on the sort of language and comprehension piece of things, and also on just pure and simple memory. So people with Huntington's disease may not recognize the spouse they've been married to for 50 years, or may look around the house and wonder when they're going home. And sometimes they say words in a sort of non-grammatical way. I had a mother-in-law who had Alzheimer's, and she could seamlessly in one sentence merge something that happened 30 years ago with something that was about to happen tomorrow with something that never happened. And I can't even imitate. I wish I had recorded her, because it was just so striking how to mush those things into one sentence. And that kind of thing doesn't really happen so much in Huntington's disease. The speech may be difficult, but the grammar and the sort of understanding of language is pretty good. And memory, honestly, is pretty good in people with Huntington's disease.
Okay, thank you. So what symptoms do you usually see when a person comes to see you?
Yeah, so you know, for years, and this harkens back to the days before we had a gene test, we neurologists were reluctant to diagnose Huntington's disease until a person had some kind of movement trouble, and that could be chorea. It could be trouble doing these sort of repetitive movements, these coordination movements. It could be subtle things about the eye movements. But we were sort of reluctant to make a diagnosis of Huntington's disease until you saw movement problems. And I think we maybe trained patients to not come see us until they had movement symptoms. But quite often the first symptoms are subtle changes in cognition. So the person says, I'm getting anxious at work, and you start peeling that back, and it's really that they're not able to multitask the way they should. They're having trouble making decisions, and so they're getting lousy performance reviews, and this is just not them. And so they come to the doctor. I always say, what's the worst job in the world for somebody with Huntington's disease? waitress. You're under time pressure. You're managing multiple things all at once. You have to have physical coordination to carry things in and out without spilling. You get the brunt of somebody's anger if something doesn't come out right. And, you're really under time pressure and getting things done quickly and multitasking. Terrible job for somebody with Huntington's disease. Best job in the world for somebody with Huntington's disease, and I always say there are two of them. One is being a night watchman. So you're in the building when nobody else is there. You have a routine that you do. You don't have to talk it to anybody. You do the second floor, and then you do the third floor, and then you go back down to the second, and don't have to talk to anybody. Do the same thing every day, and you can be very effective at that. The other one that I always think is cleaning hotel rooms. So again, when you clean hotel rooms, you deliberately go in there when nobody else is there. You have a finite task. It's actually quite, doesn't it feel good when you clean the bathroom and it actually sparkles? And so you can feel good about each unit of work that you do, and then you go on to the next unit. But if people have trouble multitasking or sort of doing cognitively loaded tasks, and then the other challenge we get into is when people have psychiatric symptoms. They say, well, I'm depressed and I'm from an HD family, so I think I've got HD. That's where the doctors really struggle, because depression is rampant among people who don't have HD. And so we really don't like to pin a diagnosis of HD on somebody whose sole symptom is a psychological or psychiatric one. We like to see some evidence of something else. I will often ask people to have formal cognitive testing, neuropsychological testing, pretty much as soon as they come in, for whatever reason they come in. Let's get a baseline. And it's kind of nice to know if it's normal. That would be great to know. And if it's not normal, that might support the idea that Huntington's disease has begun. And if it is normal, then I've got something to compare to if you come back 2 years from now or 4 years from now, that, yeah, there is a change. And that's one of the hallmarks of Huntington's, is a change from your prior level of function. And of course, when you see someone for the first time, it's always hard to tell what their prior level of function was. That was a long-winded answer, sorry.
No, that was great. Following up kind of on the diagnosis of Huntington's disease, how often have you diagnosed a person with cognitive and psychiatric symptoms but no movement?
Yeah, so it depends on what you mean by no movements. So I certainly have diagnosed Huntington's disease in people who have cognitive and psychiatric who have no chorea. Most of those people who are diagnosable with HD have some abnormality of movement. Maybe they don't have chorea, but they may have trouble doing some of our hand tasks, or they may have abnormal eye movements. And then I often ask myself, if I didn't know that you have the abnormal gene, if you just walked in off the street and told me you had headaches, would I say, yeah, you got headaches and you've also got Huntington's disease? Or would I not really pick up on that? Again, I come from a background where in the past, we really have not wanted to label somebody prematurely as having Huntington's disease and run any risk of being wrong. We had one guy once, decades ago, who came to the clinic, and he was a little bit twitchy and a little bit flaky. Nice guy, but kind of edgy, twitchy, and a little forgetful. And I knew that his brother had Huntington's disease, and I said, well, and I knew his mother had Huntington's disease. I said, well, you kind of look like you got HD. And the guy went away and didn't come back for about 5 years. And he said, I quit snorting cocaine and cleaned up my act. I got married, I got kids. Do you still think I have HD? And he was not the least bit twitchy or flaky. So, again, that was a guy who was probably high at the time that he came into clinic. And that can really mimic some of the features of HD. And we really don't want to label that person as having HD incorrectly. We'd rather fail to make the diagnosis than sort of diagnose too soon. again, some of that's going to change when we get to therapies that actually change the course of the disease. And we'll talk about that in the third lecture in the series.
So someone from our audience has written, I have hot flashes and cold flashes. Are those associated with Huntington's?
Usually not, at least phrased the way you phrase it. As I said, many of my Huntington's patients are just plain hot. They're in t-shirts and shorts all winter and have the fan blowing, and it just feels like they're sort of revving the engine in neutral and generating a lot of heat. Cold flashes, I would tend not to at all associate with Huntington's disease. And of course, hot flashes are common for other reasons as hormones change in midlife. Women commonly get hot flashes, and men can have hormone changes also later in life that can be associated with those kind of changes. So I would not immediately attribute that to Huntington's, but would sort of look for other causes first.
But moving on, how does a family establish a good working relationship between their primary care provider and their HD neurologist or Center of Excellence neurologist?
Yeah. So that's always a challenge. I think one of the things that would make my life easier is if you would bring your primary care doctor's business card with you to your appointment with me. So I actually have the guy's name and address and phone number, and I can actually send that person a copy of my report. If they are, so in Minnesota, there are several different healthcare systems that have kind of carved up the patient population. So there's Health Partners, and there's Fairview, and there's Allina. And if all your care is within the Allina system, that makes it really easy because you're all, your primary care doctor's an Allina doctor, your neurologist is an Allina doctor, your orthopedic person's an Allina doctor, and we all can sort of easily see each other's notes. And we sort of vaguely know, we get the same emails, we have the same bosses essentially. If your Huntington's clinic is as mine is at the county hospital, and your primary care is with Fairview, then you, the patient, end up having to do a little bit more of the making sure everybody knows what the other one is doing. So, bring an updated medication list. So if your internist changed your cholesterol pill, it'd be nice for me to make sure I update that on your records at my clinic. And if I change your antidepressant, it'd be good for your primary care doctor to know that. We should, in today's world, and can sometimes these medical records are linked in the cloud. But I have to say that cloud works better with some clinics than others. And so don't rely on that. Sometimes patients come in and say, well, you should be able to see my records from the Mayo Clinic. It's like, well, no, I can't. I can actually see the report of the MRI scan, but I don't actually see the MRI scan. So those cloud-based things include some stuff, but not everything. So it's helpful to, if you're going across healthcare systems, to beat me over the head with the fact that you want me to send a letter, send my notes from today's appointment to my primary care doctor, and vice versa is also nice. So that's about the best I can suggest. It's also nice. Another thing that some people do, I've had a couple patients who are unbelievably organized about this. I had one elderly gentleman in particular who had a notebook that he kept regarding his wife and her Huntington's. And every time he came to the appointment, he had his notebook on his lap, and he could turn back to the page of, well, on March 2nd, we saw the ophthalmology doctor and they said this or that. And, unbelievably organized in his own record keeping, which made my life much easier.
Do you think there are any kind of apps that we could suggest to families that they could, start to use that would mimic the old-fashioned paper and notebook?
Yeah, that's a good question for HDSA. Yeah, I mean, why don't we get out of the 20th century and move into the 21st century? Are there ways? there's, now a lot of large health programs will have this My Chart, or they call it different things, where it's a web portal that you can communicate to the medical clinic through that portal. Again, that can be more or less useful depending on how sophisticated you are and how sophisticated that healthcare system is. I've had patients be able to send, one guy said, I want to review this paper that was just written, and gave me the link to the paper. And I think other people will upload pictures of their funny little spot on the skin. And so I think those may become more sophisticated. I guess I'm old fashioned, and still it's easier for me to, if I have a sheet of paper in front of me, I sort of have to look at it. But yeah, I'm sure there are apps for that. I just don't know what they are.
All right. I think we've handled all the questions that came in. So is there anything you'd like to mention as a kind of like an incentive for people to come view our next session, which is on May 25th?
Yeah, so that session, I really want to talk more about the kinds of care needs that people have, both as they come to the doctor the first time. Doctors tend to think in terms of symptoms, but often patients and families have problems. And the problem may not map directly onto a symptom. It may be that I had 5 fender benders, and it's not, strictly speaking, something that treating chorea is going to fix. But let's address the problem. And so how do you sort of merge the kind of problems that you have with the doctor sort of thinking about symptoms, and what team members might be engaged in doing that? And then what do you do as the disease progresses? So those are the things I think it's really, I think I titled that one In the Midst of It. So, how do you, so I'd love to get questions from people who are in the midst of it, and how are you doing accessing the healthcare that you need, and what challenges are you running into, and let's talk about it.
Okay, that's great. So join us on May the 27th, 2 o'clock for HD 202 with Dr. Martha Nance. I'd like to thank everybody for their time today. And Martha, thank you for a really terrific presentation. We really appreciate it.
All right, thank you. Have a good day.
Bye-bye.
Bye-bye.